Welcome. Welcome, my digital pathology trailblazers. Let me tell you hi in the chat. We are live for our DigiPath Digest. Welcome, 6 a.m. in Pennsylvania. Let me know when you are in here. Let me know in the chat where you're tuning in from. I am excited about today's paper. I'm going to wait a little bit for you. I see already people joining, and there's always one or two people joining on Facebook. So if you're there, give it a like. Obviously, on other platforms, you can give it a like as well. And let me know where you're tuning in from. And the fun part is always like, what time is it? Is it middle of the night, morning, or whatever the time is? So as I wait for you to join, let me give you a few updates. So one update is this weekend is CAP, the conference, annual meeting of the College of American Pathologists, so a big pathology conference in Las Vegas. And I'm going to be there on behalf of a Digital Pathology Place sponsor, newest sponsor, Muse Microscopy. And Muse Microscopy, oh, welcome, Rob. Hi, Bob. Muse Microscopy is the newest Digital Pathology Place sponsors. If you go to my website, you're going to see logos of companies. These are the companies that are supporting Digital Pathology Place. There are other people, other companies as well. Not everybody gets the logo there, but Muse Microscopy is the newest sponsor, and they invited me to CAP. We're going to be creating some educational content about their device, which is a direct to digital pathology device. And Muse is microscopy based on a UV surface excitation. So basically it's direct to digital imaging of tissue. And there's a device, I'm going to show it to you. You're going to be seeing it on social media. So be sure to look at it on the weekend if you're interested in that. Okay. Oh, we have UK. Fantastic. Hi, Andrew. And we have Scott from Atlanta. Fantastic. I am seeing some regular digital pathology trailblazers here. So CAP is one thing. And I have a tool to check the accuracy of AI models. And here is the tool, guys. This is my earring. I don't know if you've seen this short, and it was on all platforms when I was at the Digital Diagnostics Summit, and there was a company, Modella.ai, and they have a tool called PathChat. So PathChat, basically, you can screenshot a pathology image, and it's going to tell you what it is. And it's still in beta, they're testing, but basically what we did, let's check what's on my earring, and we took a picture with a camera. There was a camera attached, phone attached to the microscope. We took a picture of this just with the phone. We didn't put it under the microscope, and it was like, oh, is it gonna guess what it is or not? Welcome, Brazil, Sao Paulo. Hello, and we have India as well. So going back to my story, it did guess that this was a multinucleated giant cell, but I mean, it already knows, right? So we have more. We have cartilage. Don't tell anyone what that is. And we have special stain of colon. So I have some new earrings, and it's not just jewelry for me to look pretty, guys. You know what it is for real. It's to test AI models and how accurate they are. So let me know if you want one of these. I only have earrings, so whoever wears earrings can use this tool. But maybe I'll figure out a different thing for people who don't wear earrings. So anyway, let's start. So CAP update, there are earrings. If somebody is interested, and let's talk about the papers. There is a trend today. So we're going to start with is my thing working? Yes. With the fully automated artificial intelligence solution for Her human epidermal growth factor receptor 2, this is HER2. And oh my goodness, we have people from Qatar. It's super international, fantastic. And Monica is here. Hi, Monica. Today is more oncology, but there is so the trend that I'm seeing. This is HER2, right? HER2 is an IHC marker that is being evaluated all over the world by pathologists visually. You know my opinion on visual assessment of IHC markers or visual assessment of anything in pathology slides. I call it guesstimation. So it's being guesstimated by everybody in the world. So my approach to it is like, why is there not an AI tool for this? And there is. So let's go back to our, this is JCO Precision Oncology, and our impact factor today is 5.3. And the group it's a multinational group because this was a multi-reader study, not only multi-reader, it was also multinational. We have the MD Anderson from Houston, Texas. We have Dana-Farber, France, Portugal, Sweden, Harvard Medical School, Boston, Israel. I should actually read all these centers, and I just like say the ones that I know from the US, and the rest I say the country. Next time I will prepare better, or I will be just saying the country, or I'm just gonna do it as I'm doing, because you know what, it is my live stream, so I can do that. But just to give you perspective, for this HER2 scoring, HER2 2+. So the purpose was to that the proven efficacy of HER2 antibody drug conjugate. So there is a drug, there is a therapy for treating HER2 low breast cancer, necessitates more accurate and reproducible HER2 IHC scoring. Yes, especially when it's low. When it's like super high and the cutoff, the threshold is high, then it's easy, right? We're talking about breast carcinoma, but the low ones are difficult. And if you have questions or comments, let me know in the chat. You can ask questions while I'm speaking. I'm going to go through this abstract and I'm going to see if you have any questions or comments on this, because we have pathologists on the line who can comment on different things. Okay, so there was a 2-arm multi-reader study of 120 HER2 IHC whole slide images, 4 sites, assessing HER2 scoring by 4 surgical pathologists without and with the aid of AI HER2 solution. And here we come to the problematic statement. Ground truth established by pathologists. And what are we trying to achieve? To have pathologists be more concordant with each other. So like ground truth established by a non-concordant pathologist is now guiding something that is supposed to be more concordant. But you know what? It's not a drawback of this paper in particular. It's a drawback of the method. What I would do, I would probably have it assessed with image analysis. Anyway, I don't know what I would do. I didn't publish this paper. Let's go back. But every time I hear this, that okay, the ground truth was the pathologist, that their agreement is like 70%. It's not the best ground truth. If we have objective ground truth, like the Chameleon Challenge did, so they were Chameleon Challenge was detecting metastasis in lymph nodes with AI, and there were 2 sets of ground truth. So the first one was pathologists would annotate the foci of epithelial cells in the lymph node that were indicative of metastasis to the lymph node, and there was an IHC that would stain them. And this IHC was this objective ground truth. Because everything that was epithelium would stain, and then you could compare, okay, how good were the pathologists on their own compared to the objective ground truth, and how good was the AI solution. And we have people from Yemen as well. Fantastic. Hi. So, okay, my rant on ground truth is over, and I'm not going to repeat it for the second paper that talks about similar things. But what happened was there was agreement of at least 4 of 5 breast pathology subspecialists, according to ASCO College and CAP guidelines. And this was the college guidelines. So IHC2 plus, HER2 2 plus, equivocal is invasive breast cancer with weak to moderate complete membrane staining observed in over 10% of cells. It's difficult visually, I'm just going to tell you. And if there's any MD diagnostic pathologist on the line who's doing this, let me know how difficult this is for you. It's difficult because the visual signal is very subtle. So if it's not that strong, visual estimation of that is difficult. So the mean inter-observer agreement among GT, ground truth pathologists across all HER2 scores was, what did I say? Which number did I say? 70%? Here it was 72.4. And the AI solution demonstrated high accuracy of HER2 scoring with 92.1 agreement on slides with high confidence ground truth. And the AI tool improved performance by readers. Inter-observer agreement increased from 75 for digital manual read to 83.7 for AI assisted. So it's funny, digital manual, as if you were reading with your hands, visual. I call it visual, but we know what that is, basically. Non-automated and automated. Oh, and we have people from Michigan. Hello, Michigan. Hello, India. India is so big. Let me know which region of India, because I guess you guys have a lot of time zones as well. So anyway, what we're saying here, AI improved the concordance, and also, the inter-observer agreement increased 10% almost. So that's fantastic. So what is our conclusion? And I always dream of this conclusion, like the conclusion is we're using it now. No, the conclusion is that it's good enough, but the study demonstrates utility of fully automated AI solution to aid in scoring HER2 IHC accurately, according to ASCO CAP 2018-2023 guidelines. And pathologists supported by AI showed improvements in HER2 IHC scoring consistency and accuracy, especially for distinguishing HER2 0 from 1 plus cases. Like, really, this is super subtle. I would want to have a tool for that. So this AI solution could be used by pathologists as decision support tool. Like, let's use it, guys, let's use it for enhancing reproducibility and consistency of HER2 scoring, and particularly for identifying HER2 low breast cancer. So I am seeing a trend in those papers that we are reviewing, and the trend is a lot of, and it's like, it's not really groundbreaking. It's not foundation models that can do anything. It's not the path chat that can recognize stuff from under the microscope or when you screenshot it. It's the things that pathologists are doing on a daily basis and developing tools to help them. To help them in something that is, how do I put it? Like, it is a visual task. Okay, once you know where, like, you could teach this scoring to somebody who's not a pathologist. What I mean by that, I mean, there's other stuff that pathologists do, and like, you couldn't let anybody else diagnose it, but you could tell somebody, listen, there's a cell, nucleus is inside, and if it has a brown membrane, then it's positive, and this is this type of cell. If so and so many are positive, then this is your cutoff. So, like, knowledge-wise, it's easy to understand what the score is, but it is cognitively very demanding task, especially in those low cases, low positivity cases where you're like constantly questioning yourself. Oh, is it positive? Is it not? And then like a lot of it depends like how many of those cases you review, but sometimes for studies you get a lot of them and you review 120 in a row, right? So then different types of biases come into play, like, okay, if you diagnosed or scored so and so many in a row as negative, then oh, that's too many, maybe the next one should be positive. So like a lot of visual cognitive biases come into play, and they burden your cognitive capabilities, cognitive performance, not because this task is so difficult, but because there's always this uncertainty, and you need to make a decision. So basically, AI is aiding people to make this decision faster, visually just confirming and freeing a lot of cognitive resources in the pathologist, and making them more concordant, making them faster. So I like it. It's like something that's already being done that can be done better and faster. I like it. Like, let's introduce it. Let's do it. So let me know if you have any questions, if you have any comments, if you do it on a regular basis, and what is your problem when you're doing it, especially the low positivity cases. And while you're writing all your questions, I'm going to move on to this next paper. The prediction, that's another favorite application of mine. This one is less, I would say, less close to the clinic than the other one, than the digitization of visual scoring. But the title of this paper is Prediction of Homologous Recombination Deficiency from Routine Histology with Attention-Based Multiple Instance Learning in 9 different tumor types. Let's unpack. So there is this concept of homologous recombination deficiency. This is a mutation status that is calculated in a certain way. We're going to talk about it in a second. There is routine histology, right? And we have attention-based multiple instance learning, MIL. This is a deep learning method for analyzing images where you can say something is positive or negative, and where the model takes the information from. So this is BMC Biology, impact factor 4.4. It used to be 7, but I checked today. And the group is from Germany. Is everybody from Germany? No, we have people from France and New York, and also UK, and Heidelberg is Germany. Oh, yes, that is, this group is very active in the deep learning space for pathology. So a couple of definitions that I looked up for you. So background, homologous recombination deficiency, HRD, is recognized as a pan-cancer predictive biomarker that potentially indicates who could benefit from treatment with PARP inhibitors. What are these? It's a type of drug, class of drugs that targets the enzyme poly-ADP ribose polymerase, PARP, to treat certain cancers. And what's happening there, this PARP inhibitors block PARP, this enzyme that helps repair damaged DNA in cells. So you don't inhibitors, then when you like damage the cancer, they don't get repaired. So and the clinical, there is high clinical significance of HRD testing, but it's highly complex. First of all, it relies on next-gen sequencing, but also there's a score calculation. So, oh, there is a comment that I see the comment about AI algorithms which are useful in digital pathology that are free. I'm going to address it once we're done with this abstract. And let me know if you have any other questions. And I'm just going to say hi to South Korea. Hello. I don't know if I had a guest from South Korea. Okay, so HRD, right? Mutational status. So because this calculation is complex, they wanted something based on H&E, and that's another like application holy grail of digital pathology, where you can either bypass molecular in a way or direct it. Maybe this is something that can be where instead of next-gen sequencing, you can do a cheaper test, faster test, maybe a rapid PCR or something. I don't know the exact implications, but what they did, they developed a deep learning pipeline with attention-weighted multiple instance learning to predict HRD status from histology images. Part of our approach, and in general, this approach is genomic scar HRD score. So not only, so you calculate a score and that combines different things. It combines loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions from whole genome sequencing data. They had data for a lot of patients, 5,209 patients. So you get whole slide genome sequencing, and then you take different data points from the sequencing to calculate a score, and then this score has a value, and it's either below, then it's negative, and above, it's positive. I don't know what the scale is, but I looked it up, and the score that is the cutoff score is 42. I don't know, it's out of 100, I'll look it up, but 42, if it's below 42, then it's HRD negative, and if it's, the scar HRD score negative, and if it's above, it's positive. Yeah, and this is the recognized cutoff of HRD. And what did the study demonstrate? That predictability of genomic HRD status in endometrial, pancreatic, and lung cancers reaching cross-validation ROC of 079, 058, 066, respectively. And these predictions generalized well to an external cohort with the values of AU ROC of 0.93, 81, and 73, like higher. Okay. And that this HRD phenotype occurs across different tumor entities, and they had 9 different tumors. So the conclusion is that HRD can be directly predicted from H&E slides using attention multi-instance learning, demonstrating its applicability across 9 different tumor types. So you can predict it. Fantastic. What are we going to do with this information? We don't know yet, but it's always like, okay, there is research, something can be done, and then there is real life and industry, and okay, how is it going to benefit everyone in the pathology workflow, starting with the patients, hopefully, but also cost, pathologists, and everybody who's involved. And when it makes sense, when you analyze all these things, then a technology is being pursued. So I was mentioning Muse. And this came out of the Stanford lab. I had a podcast at the beginning of the year with Dr. Richard Levinson, and his area of research, like he has many areas, but one of those areas is glassless pathology. And this was a technology he and his postdocs, his people developed there, and then they licensed it to Muse, and Muse took it. It took them several years to come up with a product that you can actually put on your benchtop, and that uses this technology and images tissue. And now they are doing clinical trial clinical trial studies with this to compare it to FFPE and formalin-fixed paraffin-embedded H&E stains, and checking the diagnostic validity, accuracy of this. And I'm going to be a speaker on their panel at CAP, one of the 4 speakers. So yes, Monica, Richard Levinson was the author or co-author of the technology. He is, and he licensed it to this company. He's still involved. So let's address the question. Can you suggest some AI algorithm useful in digital pathology? If you could narrow down this question, that would be fantastic, and that they are free. There are some free. So for example, I think there's Chi67 that can be calculated on static images. Dr. Talad Zara is writing about it. So Chi67 calculator is there. I don't remember the website, but it's something where you can submit an image even from under your microscope, from your microscope camera, and it's going to calculate you Chi67. With those online things, you always need to check what rights are you giving to the algorithm provider when you submit the image. Can they use the image? Can they use the data? Do you agree with that? Do you have permission to do that? But this one I know is free. Which one are useful? So to me, the ones that are very useful are the ones that are already being done visually, and then you can just automate them. So that's going to be PD-L1, that's going to be HER2, that's going to be Chi67, anything that is, and for research, you can do all kinds of image analysis, but everything that is already has guidelines how to score it, basically is like a prescription to build an AI algorithm. And you know what, most of them probably are going to be done by commercial entities, so you will have to pay for them. And specifically if they are supposed to be a medical device now, so there is a significant investment into making them compliant, so they will cost money. But if it's for research, you can develop your own. I think QPath is a image analysis software that is open source, it's free, and I think they have deep learning capabilities right now, or through plugins that you can use. So let me just write the name for you. QPath. When you Google this, you can, yeah, so let me know if that answers the questions. If anybody has other questions, we have one more paper today, which is similar, I don't know, not stream, similar, in parallel to the first paper. So the first paper was HER2 scoring, and here we have PD-L1 for a specific antibody. PD-L1 is another membrane marker that is relevant for immune oncology, for personalized immune oncology treatment. So there was a preliminary study on the diagnostic performance of UPath PD-L1. It's a solution, it's a software or some kind of solution, AI algorithm in patients with non-small cell lung cancer treated with PD-1, PD-L1 checkpoint blockade. This is this immune oncology treatment. These PD-1 and PD-L1, this combo is referred to as checkpoint inhibitors. I mean, there are more, but this is one of them. And this is in an Italian journal, so we have more international, and we have a local journal, and they are talking about creating automated tools for the scorings that pathologists are already doing on a regular basis. Not only Italy, my friends, also London, UK. Anything else? Mostly Italy. And what happened here? We have the UPath PD-L1. UPath PD-L1 is an AI-based platform designed to do what? aid pathologists in identifying and quantifying PD-L1 positive tumor cell in non-small cell lung cancer. And the samples were stained with sp263 antibodies. So there are several antibodies that are used for this. I mean, in research, you can take any antibody, but there are several that actually have the status of a diagnostic test, and sp263 is one of them. I'm just looking if there are any other comments. Not at the moment, but please let me know if you have any questions. So in this preliminary study, they explored the diagnostic performance of UPath PD-L1 in defining PD-L1 tumor proportion score. So there is, for each antibody, it's the best, like you have the same marker, but for each of these antibodies, there's a different score that you need to calculate. So you need to know which antibody you're using, because then the score that you're calculating, because they're several of them are companion diagnostic, so it's for a specific drug, so the cutoff differs. Anyway, one time when I was working for an image analysis company and we were doing this work, I remember that I prepared the training on like all the different antibodies, what those scores mean. So anyway, one of them is the tumor proportion score. So basically, how many of the tumor cells are affected, are positive, and this also predicts clinical outcomes in a series of patients with advanced stage NSCLC treated with single agent PD-1 checkpoint blockade and previously assessed with this antibody sp263 in clinical practice. And there were, what's going on? I cannot move my thing. I can, okay. So 44 patients treated from August 2015 to January 2019 were included, and they had a baseline PD-1 tumor proportion score of over 50, 1 to 49, and below 1. So these are the cutoffs relevant for this particular score. And then the median UPath PD-L1 score was 6, with a significant correlation with the baseline PD-L1 tumor proportion score. So there was a correlation between the automated and the baseline, which was pre-treatment. However, only 27 cases, 61%, were scored within the same clinically relevant range of expression. And what's the clinically relevant range here? This eraser is not working that great, but the clinically relevant is, no, sorry, less than, come on, are you working? It's not working. I'm sorry, my tool stopped working again. Can I do it? No, it's stuck on the, okay, now. Apologies for the glitches. So clinically relevant range of expression is either it's less of than 50 or more than 50. And if it's very little, then it's easy. If it's a lot, it's easy. There's always this like middle where half of the room, if you have like 100 pathologists, half of the room is going to say, oh, it's less. Half of the room is going to say, oh, it's more. So it is useful to have an automated tool. So the UPath, the automated tool, scored, so there was a correlation, but this tool classified those patients in a different, so to say, bucket. And if you're in a different bucket, then your treatment decision is different. And also, in the study population, the baseline PD-L1 was not significantly associated with clinical outcomes, while the UPath PD-L1 score showed a good diagnostic ability for the risk of death curve and ROC curve analysis, and also optimal cutoff resulting in 19 patients being UPath low and 25 patients being UPath high. And the objective response rate in UPath high and low was 51 and 25. So the response in those patients that had this high score was a lot higher, 51, than 25. And I'm always amazed how much lower the numbers for immune oncology drugs are when it comes to a response than any other drugs, right? So in immune oncology, what I'm used to, they're plotting the differences between the responders and non-responders, or those who have better response and non-better and worse response on the Kaplan-Meier curve. So, but those curves are not like steep; they're very flat. And we have 25, 26% difference, which is a big difference in this particular case. But if you look in general, 25% difference between treated and non-treated for something is not that huge, but yet with these drugs it is big. So although the UPath was significantly associated with overall survival and progression-free survival, so it was. In conclusion, this preliminary analysis suggested AI-based digital pathology tools, such as UPath PDL1, can be used to optimize already available biomarkers for immuno-oncology treatment in patients with NSCLC. So another proof of what we started talking about. This is already recognized as a biomarker. There is a scoring paradigm, a way of scoring this. So let's develop a tool that help us do that. I'm just gonna look if you have any additional questions, but if not, then thank you so much for joining me today. There are cool podcasts coming out, so if you want to head to the podcast wherever you're listening to your podcast, then there are cool things coming out. One on using AI in research, that should be there next week. Another thing, I actually got my husband on the podcast, but it was a very unofficial podcast. He basically let me record our conversation during lunch, so that one is coming over the weekend, and then there's going to be cap, so stay tuned. And what did we talk about with my husband? So my husband is an MD clinical pathologist, and he's been in the laboratory space for the last 24 years, 14 of those years outside of hospital systems in the industry before he was working in the hospital. And you probably have heard about the FDA trying to regulate the lab developed tests, and they've been trying to do that since 2010. And this is what he explained to me during our lunch conversation. So that's something coming out. And thank you so much for joining me. You have a wonderful day, and I talk to you in the next episode.